Okay, so my charge this morning is to answer this question, which has been addressed in the past in one form or another, and is a topic of increasing importance to us as advocates for our patients, and relevant to this day, which is focused on patient safety. So I hope to convince you during the course of this talk that the answer is yes, that opioid-free surgery is in fact possible. But I want to start by underscoring the epidemic crisis that we face and that we talk a lot about. Presently, 2.7 million people in the US face some sort of prescription medication disorder, and of these, 800,000 people are receiving some sort of treatment. And opioid overdose is now the leading cause of accidental death above and beyond motor vehicle accidents, accounting for about one death every 35 minutes. We have to understand our role in this crisis. And when you look at the misused pain medication, about a third of this medication originates from a legitimate prescription given by a physician to a specific patient. And more than half of these misused medications originate from a prescription given to someone else, an issue that we call diversion. And when you look at these diverted medications, the source in 75% of cases is either friends or family. And so it's really important for us to understand this issue of diversion, and it's come up even in the orthopedic research literature. So this was a study from the Journal of Hand Surgery that looked at a group of private practice hand surgeons and their patients undergoing either soft tissue or bony repair. And these patients, all of them across the board, were given 30 tablets of opioid medication. And at the conclusion of the study, 19 of the 30 tablets went unused, accounting for about 4,600 tablets in total. And those medications are now available for misuse if diverted. The same results were demonstrated in the shoulder world, where I spend most of my time. So in a similar shoulder research project, patients were given a standard prescription of either 40 or 80 tablets, and at the conclusion of the study, 36% of those tablets went unused. And to complicate the issue, only 25% of patients were given instructions on how to properly dispose of the unused medication. So we have too many medications prescribed, not enough information about how to dispose of the medication, and now those medications are available for misuse. So we do have a role in this issue and can make a difference. A related matter is something we call new persistent opioid use, which refers to patients that have never used these medications before and then encounter these medications during an episode of care and continue to use these medications beyond 3 to 6 months. And this Journal of the American Medical Association article showed that across all surgical specialties, general surgery, orthopedics, and others, the risk of creating a new persistent user is about 6%. And when you look at rotator cuff repair, a surgery that I perform quite commonly, that risk spikes to 10%. And if you look at new persistent use as a complication, the same way we look at infection, re-tear, persistent pain, this complication rate of 6 to 10% would be entirely unacceptable. And there are ways to predict who might be at risk to become a new persistent user. There are patient-based risks and surgeon-based risks. So some of the patient-based risks are a history of alcohol or substance abuse, the presence of anxiety or depression, the presence of a chronic pain condition or chronic neck and back pain. So if we identify these risk factors, we can perhaps manage those patients a little bit differently. And then there are surgeon-based risk factors. So if we prescribe medication for longer than 10 or 30 days with that initial prescription, we increase the patient's risk of becoming a new persistent user. If we give them a second prescription, we further increase that risk. And if we give a stronger medication than necessary, a 10 milligram tablet of oxycodone instead of 5, for example, we further increase their risk. So we do certainly play a role in increasing the patient's risk of becoming dependent on these medications. And so that begs the question, where do we learn how to manage and prescribe these medications? And this was a survey study looking at attending physicians and residents and fellows in training, and asked these respondents, where do you learn how to prescribe? And what became clear is 57% of fellows and residents recall being taught by their attending how to prescribe these medications, which means that 43% might have been taught by another resident or fellow or may not have been taught at all. And when you look at all respondents across the board, about half recall never being formally taught how to manage opioids. So there is a clear need for standardization and guidelines as we approach these medicines in practice. So the holy grail for us is, of course, minimizing opioid usage in our surgical patients, as we've been talking about. But we don't want to do so at the expense of pain. We want to minimize opioid use and minimize their pain scores in order to maintain patient satisfaction and have a good outcome. And we have partners in this effort. So a variety of national organizations, the CDC, the Joint Commission, the American Academy of Orthopedic Surgeons, American Society of Anesthesiologists, and the American College of Surgeons have all underscored the importance of educating patients and surgeons on safe prescribing and usage of opioids. And this can be accomplished through something we call multimodal pain control. So this refers to the simultaneous use of multiple medications acting at both the central and peripheral nervous system in order to reduce pain and in order to decrease opioid usage and avoid those opioid-related adverse events. And there's basically two pathways for multimodal pain control: the pre-admission and post-discharge pathway, and then the perioperative pathway. So this battle really begins in the office before the patient ever hits the hospital or the operating room. Every orthopedic practice should have standards of care and best practices for how we prescribe these medications. And our practice has done this. We have specific guidelines that dictate how many tablets a patient will be given, dependent on what procedure they're going to undergo. So a knee arthroscopy will receive no more than 5 tablets and may not even use those tablets. And a shoulder replacement patient will receive no more than 30. And those numbers are likely to continue to decline as we get better at multimodal pain control. Probably the most important part of that pre-admission process is a conversation that we have with the patient. We bring our patients back to the office for a dedicated preoperative visit, and we counsel our patients about how much pain they should expect to experience for how long, and we give them detailed instructions about how to use their medications. And as important, they leave with a piece of paper, a set of instructions that they can refer to when they go home so that they can adhere to the pain control program that we've established. And if this is the only change one makes in one's practice, the literature shows that you can decrease opioid usage while still maintaining effective pain control. This is what our multimodal pain control program looks like for most patients. We give patients a standing dose of Tylenol, which can make a difference. We give an anti-inflammatory, usually a short course of Toradol. We use gabapentin, which is a neuropathic pain medication, but has an additive effect when used with these other medications for a period of 5 days. And then we do give them that oxycodone, but we give it to them only to be used for breakthrough pain. We no longer tell patients to, quote unquote, stay ahead of the pain or begin to take a standing dose of oxycodone, because we now know it's not necessary. That's the pre-admission post-discharge pathway, and one of the most important aspects of multimodal pain control is what happens in and around their surgery, the perioperative period. Our anesthesiologists help us a great deal with regional anesthesia. This encompasses a wide array of techniques, epidurals and spinals, for example. But as extremity surgeons, we often rely on peripheral nerve blocks, where the anesthesiologist uses a needle to target a specific nerve or bundle of nerves, inject medicine in and around those nerves to provide sustained anesthesia during the immediate postoperative phase. And there are a variety of ways anesthesiologists have made this technique safer. One of the things they can use is a nerve stimulator. It's attached to the needle that they use. And as they're inserting the needle, they stimulate the nerve, and if they get the appropriate motor response, they know they're in the right spot, and they inject the medication. In addition to the nerve stimulator, they can also use ultrasound guidance. We have the luxury of working with incredibly experienced and talented anesthesiologists who are adept at ultrasound, and they can directly visualize the nerve or nerve bundles, and they can directly visualize the needle, position the needle accurately, and inject the medication to improve the effectiveness and safety of their nerve block. The medication we normally use is bupivicaine, which is a relatively longer acting local anesthetic, but we want to, if we can, try to extend the action of the bupivicaine, and one of the ways we can do that is by adding steroid or Decadron. If we mix bupivicaine with Decadron, we can take a block that might last 12 hours and actually get upwards of 18 to 24 hours of near complete pain relief for our patients. We certainly would still like to have even longer pain relief if possible. And one of the ways we can do that is by using an indwelling catheter, where instead of a single shot block, the anesthesiologist can place a catheter next to the nerve and use a pump which slowly delivers bupivacaine around the nerve over several days for patients that might have chronic pain issues or might be undergoing a procedure that's uniquely associated with pain. But we continue to find ways to extend pain relief associated with nerve blocks, perhaps without having to rely on indwelling catheters. And one of the medications we now have at our disposal is this liposomal bupivicaine. A liposome is a minute spherical sac of phospholipids seen in the middle panel, which can encapsulate a medication and can be used as a vehicle to deliver medication to a site. It's currently being used in infectious diseases, autoimmune disease, cancer treatment, and now with Exparel, it's being used in analgesia. And Exparel relies on this depot foam, which is a multi-chambered liposome, and it can encapsulate this bupivacaine medication. And as it's broken down during the normal metabolic pathways, it slowly delivers a therapeutic dose of bupivacaine to the surgical site. And when you look at the pharmacokinetics of Exparel, we see that it can actually deliver a therapeutic dose of bupivacaine to upwards of 72 hours, which can be incredibly useful to us in trying to stave off the need for narcotic pain medication. It's typically been used as a field block, which means when we're performing open shoulder surgery, we inject the medicine to the different sites that are affected by the procedure. So you can see here on the left panel, we inject some medication above the socket to the area of the suprascapular nerve and inject some more at the base of the coracoid process where the biceps tendon originates. On the right panel then, we also inject into muscles that are manipulated during the operation, the deltoid and the pectoralis. And then on our way out, we inject the subcutaneous tissues. One of our partners, Paul Sethi, has also described a way to use this medication for arthroscopy patients where there isn't a large exposure and we can't access those tissues directly. This technique allows us to target areas that are affected in our arthroscopy patients that might be undergoing rotator cuff repair or labrum repair, for example, and provide the same level of sustained pain relief. And anecdotally, we've seen good results when we ask our patients how much narcotics they've required.
I've had rotator cuff surgery. I took no narcotics and was off painkillers within a week. And this is my range of motion now.
So pretty remarkable stuff and something we never would have seen even a couple of years ago. Now that's rotator cuff repair, that's soft tissue work. What about when we're doing a shoulder replacement and machining the humerus and glenoid socket and placing metal and plastic parts?
I'm Evan Williams. I'm an attorney in Troy, Pennsylvania. I had a total shoulder replacement, a reverse variety with Dr. Sethi. And I took no opiates at all after the surgery, and I really had no pain of any significant nature. I'm very pleased with the results so far. It's only been a couple of weeks, but I'm not taking any pills now, not even Tylenol.
So thankfully, these patients have agreed to share their story with us, and we're finding that this is no longer unique, that we are seeing many more patients that have had a similar experience. And it's not only anecdotal. The ONS experience was recently presented by Dr. Sethi at the American Shoulder and Elbow Surgeons meeting just this past October. And when adding this Exparel to the traditional multimodal approach that I've described, we've seen a significant decrease in pain scores over the first 48 hours after rotator cuff repair, and we've seen a significant decrease in the number of oxycodone tablets used over the first 5 days, with a total reduction in opioid consumption by 64%, which is significant. The next frontier for things like Exparel is, instead of using it in a field block, which can sometimes be less predictable, it's now been FDA approved for use in peripheral nerve blocks, and we are starting to use it in this way for our shoulder replacement patients. And early research has shown similar results, more consistent results, a significant decrease in pain scores and significant decrease in total opioid usage, at least out to 48 hours. So in summary, prescribing patterns on behalf of the physician can contribute to opioid misuse. Effective multimodal pain control begins in the office. Anti-inflammatory medications are safe and effective for most orthopedic surgery procedures. Peripheral nerve blocks have improved in safety and effectiveness substantially over time. And this Exparel, this liposomal anesthetic, has had a profound impact in our ability to avoid opioid usage in our patients. So opioid-free surgery is certainly possible. Thanks a lot. Appreciate it.